Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr.Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello, everyone, and welcome to another episode of the Sleep is My Waking Passion podcast. I'm your host, Dr. Alison Kole, and today I am joined for a very special revisit. It's been a minute since I've had really deep conversations with a dental sleep medicine expert, and I want to introduce you, if you have not already heard of her, she is all over social media, to Dr. Maria Sokolina. Welcome.
Good afternoon or good morning, Alison.
Yes. So if you want to find out more information about her, I'm going to have all the links in the bio, but you can find her at njdentalsleepapnea.com. She has two offices where she sees patients. She sees them in Clifton and in New York City. She is deeply passionate about dental sleep medicine. She has been practicing and focusing on sleep for over 15 years. She is a true expert in her field, and she is on a mission to improve collaboration amongst medical professionals and dental professionals. And she loves to talk about sleep. We really hit it off hanging out at the Philadelphia Sleep Conference. So it is such a pleasure to have you on the show.
I'm so honored. And it's true example of a collaboration, what dentist and a medical doctor can talk. I think it's really changed the life of a lot of patients and give them more options in the sense of diagnosis and awareness, as well as in the sense of treatment.
Absolutely. I can't tell you how many times I've had a referral, and it's primarily because a dentist has flagged that there's some changes in the mouth that look consistent with sleep apnea. Speaking of which, maybe we could start with that. Can you elaborate for the audience, what are the type of things when you're assessing a patient, even if they're not coming to see you for sleep apnea, that would make you really concerned that they have a bigger problem than meets the eye?
Yeah, this is a fantastic question. And I think we as a dentist in that very privileged seat. We are right there. We have a continuity of care. That means trust with the patients, with the 6 months, 3 months, 4 months cleaning. And we have those very special relationship. I know relationship with the dentist, they're very intimate because this area is very intimate. It has a lot of nerves. It has a lot of apprehension through the media. So it's a very special relationship with that person. Patient establish those relationships. Sometimes they are friendly, sometimes, whatever it is. So as a dentist, we have that first row seat of the science of the sleep apnea. Truly. And very often with the, I'm going to talk about my office, but probably it's a standard of care. Very often we take pictures, and it's so sad over the years to see the deterioration or maybe changes in a patient mouth. I'm going to talk about most visible one. Let's start with attrition. Let's start with the changing of the size of the teeth. It's very hard to see in the mirror because, you see yourself, you look good, teeth look good, they look white, but very nice sign if you see your bottom front teeth and they have sort of like colors, 2 white colors and a dark yellow in the middle. That's the sign of the dentin. Teeth should have enamel on the top. But if you see the soft tissue of the tooth, it's not soft like sponge. It's just soft in the sense of attrition. If you see the dentin next to the enamel, that means you're grinding your teeth. Now let's talk about grinding. We're here talking about sleep. So when somebody have apneic episode, body is very smart. So patient wake up, remember it or not, and it's a signal to move the jaw forward to open the airway. That's why very often those signs on the teeth can be as a nighttime bruxism. Another sign, and some people say, I don't grind my teeth. Maybe I do something at night. So they're aware of it. Also, in addition to those signs, if dentists mention them, they can say, yeah, my jaw feel very tight in the morning. So that's a lot of activities. Like people consider night as a quiet time, but actually you and me, we see the sleep study. And it's more like a marathon.
Right. And so is there a difference in terms of risk for sleep apnea or signs that you look for between a clencher? Some people clench, but they don't necessarily rub their teeth together. It's the rubbing that's more of the bruxing or grinding of the teeth. Is there a difference in terms of risk, or is that sort of along the same spectrum?
I would say science is not a closed book, and we know about that, just the tip of the iceberg. I would say I call both of those activities sympathetic response. So let me talk about clenching and let me talk about grinding. So clenching, my research, lifetime research about clenching. What clenching is a search for balance. It can happen at night as well. But usually in the daytime, very often people looking for balance, either emotional or physical, and they use the teeth to feel that balance. Sometimes they're not balanced on the feet. Sometimes they're not balanced in the sense of posture, balance towards working. And very often they clench to sense that balance. We're a very sophisticated system, human body. So that's the clenching. Now, grinding, very often I attribute grinding to movement of a jaw forward to open the airway, or we say bruxism. But for clenching, and very often I see it on sleep apnea patients because I refer to sleep doctor to prove my hypothesis. I see, as a result of clenching, huge tables next to the bottom front teeth. We call it tori. We call it growth of bone. It's actually also restrict tongue space and tongue pushed in airway, but that can be the result of clenching as well as, that's the sign of sleep apnea. Also, very interesting thing on the teeth, I call them abfractions. It's like a step inside the tooth. It happened from that load, and the enamel just come off on a cheek side of the teeth, and you see like step in. That can be sign of occlusal bite activity at night or during the day. So that's another sign. Now I love the tongue. I love looking at the tongue because tongue is such a powerful muscle, but it's not so known. But on my channel, Sleep Apnea Breathing Snoring Help or Instagram, we talk a lot about this magical organ. This is a muscle what actually shape our face. So when I look at the tongue, very often I see the space between the teeth as a result of tongue being in between the teeth upon swallowing, and we swallow like 900 times a day. So we call it open bite. It can be in the front or in the back. And I see indentation of the tongue. We call it scallop tongue. That's another sign. I love looking at the patient throat. And sometimes I cannot see the throat. Just soft palate and a uvula somewhere in the area of lungs, hanging somewhere here. Of course, no wonder it collapses at night. So I would ask patient, can you open your mouth? And they open. I see just the soft palate. I can ask them to say ah. They say ah, but I don't see the end of this little tongue called uvula. And then I ask them, do you snore? And a lot of times, oh, I just snore a little. And then that's how we start that conversation. I made a survey or, fun test for people to define if they sleep well. I put it on Instagram and I would love to share it with your audience, but they can kind of assess themselves using those signs, using, some little tricks or tips what body signal them. Okay, I'm in trouble. I don't sleep well. Don't expect to feel refreshed in the morning. Everything is right here.
Wow. Okay. So I love that. There is quite a bit of overlap. I haven't spent as much time on the tongue, but what Dr. Sokolina is describing is that in the medical parlance, we call it a Mallampati score, which is basically like we look at the back, we have the patient open their mouth, they'll stick their tongue out. And if they're not activating and saying, actually triggers muscles in the back of the throat. Sometimes even when you trigger it, you can't see anything. That's a pretty restricted airway. Sometimes what we see is that the soft palate's kind of hanging down, but once we activate those muscles, we can kind of get a peek at it. Still significant because you have to imagine you're not sleeping all night going, ah. And then there's other folks where I can make out what their uvula looks like, how big it is. Does it hang down? Does it touch their tongue? For some people, it does. I can see, do they still have their tonsils? Sometimes we catch adults, and on rare occasion, when I've seen relatively young adults with giant tonsils and pretty bad sleep apnea, I don't normally refer for tonsillectomy, but it's a logical sense that person's going to have a restricted airway. And so I have done that on occasion, referred patients to really be considered for tonsillectomy. Other times everything looks okay. And one of the tricks is all the things that she's telling you are all suggestive of, but not really key diagnostic. You can't just look in the mirror and figure it out. And the trick too, that I'm sure Dr. Sokolina is going to get into is, we know that many people who have obstructive sleep apnea, and that's really the focus of our conversation today, do not necessarily tolerate the gold standard, which is CPAP or auto positive airway pressure these days. We use these auto titrating CPAP machines nowadays. And when they don't tolerate it, we need to consider alternatives. Unfortunately, my understanding is to date, and maybe you could tell me if you have any tricks to up that probability, it's very difficult to really determine which patient's definitely going to respond to oral appliance therapy. I feel like I'm being ridiculous for showing this because I have a dentist on my show. I mean, this is a silent night, so this is not a real robust oral appliance, but I like it because you can kind of see what I'm talking about, upper and lower. There's many, many different brands. Dr. Sokalina is showing you another brand. The bottom line is the idea is you are really kind of gradually bringing that bottom jaw forward and you're helping to hold it in a more optimal position. Do you know if there's any data that says that the grinding will resolve when you use an oral appliance, or do you still have patients who grind despite using an oral appliance?
This is an interesting question about daytime or nighttime. Okay, let's talk about daytime. And yes, you put it in such a beautiful words about CPAP machine. CPAP machine is a golden standard, and that's why on my lecture I want to point it out. Not CPAP machine versus oral appliance. No, CPAP machine and oral appliance. That's the best therapy to control the blood pressure according to the latest research. That's why collaboration in the dental sleep medicine, it's really extremely important. Yes, there are a lot of designs of oral appliance and grinding. It's a great question about grinding. According to the theory, what we think, what people grind to open the airway, and if airway open with the CPAP pressure, supposedly they should not grind. But practice show me otherwise. I have a lot of patients on a CPAP machine and I see the diminishing of the tooth structure. And usually, they complain on the jaw joint and all of that. A temporomandibular joint pain is not contraindication for oral appliance. We want to, let's call it, disocclude, open up the space in the jaw joint, or if we be more scientific, we want to move the head of the joint to the more forward position, away from the nervus plexus, which is in the back of a joint. So we're kind of repositioning the jaw to safer place, to put it on a disc. I don't believe in a maximum titration, maximum advancement. It doesn't have to be that way to open the airway. I think not for everyone, we cannot say golden standard for everyone, but usually I suggest with a minimal opening, vertical and horizontal, and mouth being closed, not shut, close to the point where people can open it. That can be the best way to address grinding for people who have CPAP therapy or for people who have a sleep apnea in combination with the machine.
Wow. So do they actually then decrease the amount of grinding that they do? Oh, wow. So that's fascinating, because what you're saying is if you're on CPAP, and I can fully wholeheartedly agree, and I don't even need a study to tell me this because I just see patients and I know this happens, they'll still grind with the CPAP. You're right. And they seem to complain less about it, but I wasn't sure if you just don't see anything because, well, you grind. So we've now kind of repositioned your jaw into a more optimal space. logically you'd think it would decrease, but I wasn't sure if they just were getting their teeth protected because now they have two barriers instead of one. But it sounds like it actually might decrease.
You know, like this, if we're talking purely scientific, for us to sleep, we have to be in a parasympathetic mode. Grind is a sympathetic mode. So to be in a sympathetic mode, it's not only disocclusion of the teeth, it's also tongue position. Like we want to make sure tongue is stimulating nervus vagus, being on the roof of the mouth. That sometimes not with the oral appliance, it has to happen with other, maybe with myofunctional therapy. That would be the good approach. And you asked me that question, how do we know in advance who would respond the best with oral appliance? I have a realistic thought and I have a hopeful thought. So one of my friends, Dr. Lambert, he highly believes with artificial intelligence, with all the logical steps, what it can do. You put the patient information in, and then it's going to give you the algorithm, what treatment going to be the best. But from my clinical experience, what I believe into, best treatment can be for that particular period of time. And it will be some period of time when CPAP machine is the best treatment. It will be time when oral appliance is the best treatment. It will be the time when combination therapy is the best treatment. And I mentioned in a conversation before the interview, I'm writing a book to show what variety of treatment with different pro and cons, like in any treatment, and person have a right to choose the treatment, and it's a doctor's job to advise at this particular moment of the life what would work the best.
I love the fact that, speaking of collaboration, that you mentioned that, which I don't do that often, simply because it kind of depends on the patient and whether it's necessary, which is a combination of oral appliance with CPAP. What we have found is that when you combine moving and keeping your jaw in a more optimal position, so your airway is just in a better kind of position, and then you have a mask, you can achieve a remarkable result. And often what you see is that the pressure requirements are lower because CPAP really is just kind of blowing air to help keep this upper airway open. And the one thing we know is that sometimes some people need a really high pressure. Some people have a lower critical opening pressure, so they don't need as much. And sometimes people just perceive that sometimes the lower pressure feels like a lot to them. So some people have a different threshold for tolerance of various pressures. But it certainly can be really great for a more challenging position, a more challenging patient who may have very high pressure requirements, and maybe we need to be creative. Maybe they need to sleep on their side. I mean, I've had patients where I've done everything. I've done the APAP. That's not enough. I've done the BiPAP titration. And we kind of go through this whole thing and we realize, hey, this person's really just going to always have some residual obstruction. Let's start to combine therapy. And then we really get somewhere. Because our goal always is, if we can eliminate sleep apnea, hooray. But a lot of the treatment options that are non-CPAP, you may not fully get resolution, though I have heard with oral appliances that sometimes you can be very surprised with the degree to which sleep apnea can resolve on repeat testing.
Mm-hmm.
Can you talk a little bit about what you expect in terms of improvement for patients, and what's your counsel methods like? Like, what are the key things you want patients to take home when they're considering an oral appliance?
That's a kind of several layer question. So I would say golden standard for my treatment, I want to have a sleep study after the treatment with AHI below 5.
So you really strive for perfection. That's what I'm hearing from you.
I really want that. And I try to approach that comprehensively, and I'm going to talk about that. But during the initial consultation, I try to understand that person on the other side of the screen. My first consultation is usually, just like our podcast, through telemedicine, because I want patient in the comfort of their home to see another person who listen and understand. I'm trying to find the reason why they have apnea. Of course, not always I be able to find it, but listening to the story, connecting the dots, talking about the discomfort they experience, learning about that helped me with my therapy. Because very often what I found is lifelong story of allergies. I always look at the nose. We talk about science in the mouth, but for me personally, I don't. Not only I look at the mouth, I usually look at the nose. And it's not far. It's right here next to the mouth. So I just said, is it okay if I take a look at your nose? And I do see enlarged turbinates. And I do see them like a brutally red or, that whatever color, bluishly red inside the nose. And, we start that conversation gently. So lifelong history of allergy usually define tongue position. And, we talk about tongue. And I know that's when I talk about that with the medical doctors on my channel, Sleep Apnea Briefing, Snoring Health, a lot of doctors like a little bit different because we as a dentist, we learn to be very good observers. And, you cannot take it away. It's just there. So when I talk to my patients, going back to the patients, I talk a lot about nasal breathing. And I talk about tongue position. But what I learn, I want to make the nasal breathing easier. And I talk about different tricks, what they can do to make it easier. Yes, there are, a lot of people talk about breathing strip, and I see it on a highway when I drive to Manhattan. Even the billboards talk about that. But, I recommend them expand a little bit of the nostril, especially people who have a strong valve which collapse, because I believe it's then approach that critical pressure, nasal collapse.
Can I pause for a second just because I think you brought in such a cool point, and it's one that's often overlooked, and I actually learned it specifically from an ENT specialist or an otolaryngologist. I didn't really truly understand the idea of your nasal valves malfunctioning, but one of the easiest ways to see it, and I've seen so many commercials for various types of things that deal with that, not just the mute, which you showed, but there's a ton of them out in the market.
Yes.
But the easiest way to tell, because you guys can at home do it, you just look in the mirror, tilt your head back, look at your nostrils. So when I breathe in, my nostrils are kind of open. I fortunately, thank you God, I don't have major nasal obstruction because it's a real pain when you can't breathe through your nose. Some people, they'll breathe in and you'll see one nostril go like that. When they breathe in, they'll be like that. And then you really know that's like the easiest sign to tell, hey, you've got some nasal valve collapse there. And really what helps them is it's not about fancy surgeries and getting scopes up your nose and all of that. It's like literally what you're talking about. A breathe right strip, a mute, nosovent's another one that kind of goes in the nostrils and kind of flares them open. That can be hugely helpful. And you could really have a much better night's sleep. So thank you for pointing that out because you are correct. Dentists, they talk to you, but when you go to the dentist, they're really examining what's happening, what's going on with your enamel. They're very detail oriented. I went to Tufts for medical school and we share, Tufts Dental School of Medicine, and y'all are hardcore at Tufts, let me tell you. So I actually truly admired and liked working side by side with them. We shared the cadavers because of the head and neck area. And it was always fun to have a dental student come and assist with dissecting things. And then everything's all pointed out for this pulmonologist who's like, there's a lot of stuff going on in the head and I want very limited exposure to that. So thank you for that. Great point.
Yeah. So, you mentioned, there are, not specifically mute, I don't want to be towards the company, but I want to point out to the nose, which is critical step for success of oral appliance therapy.
I never thought about that. So
yes,
if you see that, then you will help open the nose, which will make it easier to breathe. And then you can combine that with oral appliance and it's like the double whammy.
Absolutely. Always. I always do to increase the success of my therapy. Nose is, 90% of success. Not the moving the jaw to Manhattan, but nose.
And I also love that point because I do think that some dentists who are dabbling in sleep, and there's a difference between dabbling and truly being committed to the literature. sometimes they really do opt for like, we just need to get them maximally titrated. I'm like, really? But do you? And you and my good friend John Carollo are very much aligned. You want to move the jaw in a position that will most stabilize the airway. How do you base that response? I have seen people, because some of you folks have like panoramic kind of x-rays and images like that.
Yeah, I do have it too. Yes.
So you can kind of actually see the airway. Is that part of your practice of sort of assessing when you think the patient is right for testing? Or is it a combination of symptoms and response? Like, how do you approach that before you go refer them back for sleep testing?
Absolutely. This is a fantastic question. We always have Epworth and fatigue subjective scale. That's number one, how we start. Also, I use Snore Lab, and my dog also wants to participate in our conversation. And this is Sage. She actually snores.
Oh, yeah. She's got sleep apnea.
Yes.
Hi, pretty girl.
So she's going to be with us on the show. We start with that to begin with. It's initial. So I have a sleepiness level, I have a fatigue level, and I have recorded snoring. Besides sleep apnea test, I have a lot of variables, and we have mutual friends who so much into variables. And of course, I learn a lot from our friends. If some of my patients want to use sleep-on ring to know about HI, be my guest. If some people want to use Aura, I try to give recommendations based on the device they use to assess. A lot of time I ask about how many times they wake up at night. I usually say that magic phrase, and it really works. If I have a magic wand and I can change something about your sleep, what do you want it to be? And people express what's most important for them, not being tired. And I ask what exactly it means to be tired. And I remember that lady very clearly. I have a dog too, and I really want to walk them in the morning, but I'm so tired, but I don't have that energy. Then every time she comes in and I ask you that specific question, did you have chance to walk your dog in the morning? That helped me to assess in a very human way. And some people said, I really, I would like to make a walks, like different things. But what I love about that, when people come to my appointment and I ask them how they feel, they share. Some people share, today I wake up in the morning and my apartment look like a mess. I get up and I start cleaning that. Then I know they probably are ready to have a sleep study done.
Do you know how long it takes in your estimation when people can expect that they're probably going to be optimized? Do you have a time frame that you set expectations for?
I usually talk about 3 months. Of course, we're all different because this is a treatment. It's not the appliance what treating you. It's a therapy because I have to take something and put in a suitcase. I'm talking about human life without breaking a zipper. I have to change a lot of habits. Not only put the appliance in the mouth, but we're talking about nasal therapy. We're talking about a lot of things. We're talking about sleep hygiene, your big topic, about different things what can improve how patients feel in the morning if they feel refreshed. It can be different things. So 3 months I take, sometimes take longer, sometimes it's much less.
Well, I got to tell you, Maria, this has been such a fun conversation, and I'm really excited to continue it because we are doing a double whammy today. We're doing this part, which will be on the Sleep is My Waking Passion podcast. And conversely, now I'm going to go talk about all sorts of fun stuff like difficulty sleeping on Maria's podcast. I'm going to call it a podcast, her show.
Yeah.
So this has been such a mutual, fun collaboration. Just know, if you are a patient or even a provider, that you can find kindred spirits in the sleep community. And if you are not satisfied with who your sleep community is, trust me, we're out here, and many of us would be very happy to collaborate. And we also have friends. It's a small world, so we know who the good eggs are. We're happy to help you connect with them if they're more local to you. Maria, Do you want to say any final words before we jump off and go on your show?
Absolutely. If you're not sleeping well, I'm so passionate about the topic. You can become part of my community, Sleep Apnea Briefing Snoring Help, on Facebook, YouTube, LinkedIn, or you can follow me on Instagram, Dr. Maria Sokolina. And I do reply to the messages. I would be very happy to connect if you are the colleague, medical practitioner, or if you are patients who going through challenges. I would be very happy to direct you to the proper source. And I really wish you have a restful night's sleep and feel great in the morning. Thank you very much, Dr. Kole, for real example of collaboration where two professionals can talk and express the professional opinion, share the tips and tricks, and just be practically helpful.
Thank you.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.